Okay, and we should be live. Hi, everyone. Welcome to another virtual session with Dental Shadowers. Today, we're thrilled to welcome Dr. Torculas, general dentist based out of San Diego. Dr. Torculas, thank you so much for taking the time to meet with us.
Thank you for having me.
Yeah, please feel free to take it over or take it away whenever you're ready.
Cool. So I'm Dr. Daryl Torculas. I am a general dentist here in San Diego, born and raised in San Diego. Let me just go through this PowerPoint. So I am a recent grad, graduated in 2016. It's within 5 years, so still considered a new dentist. I currently work as an associate part-time, and I have my private practice in Linda Vista also. I'm part-time there as well. And like I said before, I'm from San Diego, born and raised. And I recently had a daughter. Her name is Aria Lynn, born in August 2020. And that's her and her baptism. So my journey to becoming a general dentist, I went to UC Irvine, graduated in 2011. I took a year off, which means I didn't get in my first try. You apply my junior year of college so that you get accepted by your senior year, and then that senior summer you can roll right into dental school, so you don't take any time off. Felt a little ambitious, didn't get in. Also didn't really prepare that smart or effectively for that first run. So that year off, I worked at an ophthalmologist office. I applied again, this time 27 schools. Yes, that is a lot of money. I got 5 waitlisted. So 5 interviews, and then those 5 that gave me interviews, they waitlisted me. So around December 1st, I wasn't informed that I got in. I was just told on the wait list. And then I had 1 acceptance. I took the first one that accepted me, which was also the one that I really, really liked. And then I had to tell all the other schools that waitlisted me that, hey, I've accepted to go to IU. So I went to Indiana University, had no idea, actually never been out to the Midwest except for my interview. Great school though, loved it, had a great time on the interview. It was 2-day interview, so they pretty much pulled out the red carpet. Best 4 years of my life. And then I went to Ohio State for residency at a GPR for 1 year, 2017. Decided to move back home because I couldn't handle the cold. It was cool and all, but at a certain time when it's freezing around April, May, you kind of get tired of it. So decided to go back home. Worked as an associate, or currently work as an associate now, same place that took me. So I've been at this associate since 2017, and I recently acquired my practice in February of 2019. So, yeah, let's move on. So, what is general dentistry? General dentistry, there's a lot of things that you can do in general dentistry, but you can pretty much diagnose, treat, and manage the overall healthcare of a patient. So you're pretty much like the quarterback of the patient. You can do a lot of procedures, going from preventative, so x-rays, cleaning, exams, and then you got your fillings, you got your root canals, you got braces, orthodontics, you got some implants, you got your dentures, crowns, bridges, and then there's your cosmetic cases, of course, your veneers, full mouth rehabs, and then, we are doctors with a focus of the mouth. So you still have to look at the individual as a whole. And sometimes, as dentists, we forget that. So there's a lot of things that you can do. The beauty of being a general dentist is you can pretty much practice as a specialist. The only caveat is you're going to hold yourself to those standards of the specialist, because you can charge however much you want. You can even charge specialist fees, but if you don't, perform to that caliber, then people are going to start questioning you. You're going to get a bad reputation in the community, and that's where the beauty of general dentistry is. Like, if I don't like doing root canals, I can give it to my associate or someone else. If I don't like doing fillings or cleanings, I don't have to do it. You can build your practice the way that you want so that you can enjoy and have a long career.
Is that flexibility what sort of drew you to general dentistry?
Yeah. General dentistry, there's a lot of things that you can go to. And then I think one of the big things that drew me into it was, we're in this age of instant gratification. So if a patient comes in, hey doc, I'm in pain, chances are you're going to get them out of pain that appointment. You're going to do the best you can, because if they leave and they're still in pain, they're going to go find the next dentist who can get them out of pain. So the good thing is, you have an immediate impact, whether it is fillings, cosmetic, composites, veneers, you have this huge impact, to help someone with their smile. And then, they can eat again, smile again. The emotional value or component to the patient, and you'll know right away once the appointment's done, like, okay, I did a good job or I didn't do a good job. So it goes both ways. It can be really, really, good for you, but also like if you think you did bad work or could be improved upon, you're going to go home sleeping, and sometimes you can't sleep at night with that. So
Right.
it goes both ways. But yeah, being able to choose your own path, choose what you want to do. That's the beauty of dentistry. And you don't even have to practice dentistry, to enjoy dentistry. You can own multiple businesses if you're into, the whole business aspect. You want one office or one practice or multiple practices. You can have a one doc office or multiple docs, multi-specialty. It all depends on where you want to go. You can go to public health, community health. So going out to those rural areas and just seeing those patients. Granted, for those patients, fillings, the basic drill and fill, versus if you had your own private practice, you can do whatever you want kind of ordeal. So yeah, there's a lot of ways you can go about it. There's also pathology. If you go through dental school and you're like, hey, you know what, my hand skills aren't great, but I do like dentistry. So those cases where you have the oral surgeon can send you cases of like, hey, I need this diagnosed. I don't know what this is. Is this like a squamous cell carcinoma? You look at the slides, then you just look at and you diagnose it, with that. So you don't even have to pick up a handpiece, but you're still a dentist. So there's multiple avenues that comes from general dentistry. It's, being able to find one that you like and then, going towards that. All right. Did I skip? Okay, so yeah, I'll go back. So here's some advice for college. Prepare. The biggest thing that I learned was simulating your DAT exam. I'm not sure what it is now, but back when I took it 2010, 2011, it was a 4-hour exam. And you want to simulate that. So, okay, if I'm going to take it in the morning, prepare as if you're going to take it in the morning, take that test, do multiple exams for that. So you perform to the level of your training and practice. You think you're going to do well in the exam. Chances are, if you're not doing well in your practice, you probably won't do well in your actual exam. And that's just how it is. Don't spend all your time on the things that you're good at. So if you're good at the PAT and like, hey, you know what, I can count these boxes, you're good at 3D and you've been scoring 23s, 24s, chances are you don't need to work on those, work on your weaknesses. So if it's organic chemistry, your reading comprehension or whatnot, then, focus on those because, you only have so much time. It's easy to, trick yourself and be like, I did well on this, which you already knew that you're good at it. What about all the other things to help boost up your score? Another thing is extracurriculars. So, I took the DAT, I worked from ophthalmologists, and it's random, right? You would think I would have worked at a dental office. In my whole 4 years of undergrad, or working up and getting into dental school, I did not work in a dental office. I shadowed a few times but the bulk of my experience in dentistry was doing these dental trips in college. So I'm pretty sure you guys have those. For me, it was global brigades. So we had a dental part with a dental team with the medical team. So, we went on those trips. We brought our own doctors, extractions, fillings, cleanings for those patients. We didn't do it. We had the team had to find the doctor, and then the doctor would bring their staff. And then it would be for about 2-3 days of working on patients. And obviously you got to do well in your classes. I had a 3.3 at UC Irvine, but then my DAT was, I want to say 20, and then my PAT was a 22. So with that being said, it's doable. It's challenging, but once you get in, you're in. And by far, getting in is the hardest part of dental school. Once you get in, it's just a matter of passing your classes. I know that sounds kind of like, wait, what? But at the end of the day, you got into dental school, and as long as you don't get kicked out, you're going to do well because dental school prepares you to do well. You'll be fine. And I graduated I was ranked 33 in my dental class. So out of 100, 105, you just got to work hard. So I think working to get into dental school was a lot harder than me studying and performing in dental school, in actual dental school. A typical day in general dentistry, like today, I worked at the associate office. So woke up at 7:30, you wake up, breakfast, get ready for clinic, get into clinic. So my commute is about 45 minutes, 30 to 45 minutes, morning huddle with the team. So 8:45, you pretty much go over the team, depending on what office you're at, usually it's the office manager or the lead assistant that tells you, hey, doctor, we have these patients that we're seeing today. This is the general, you're going to go here. They're going to direct you pretty much where you're going to go. And then, that's pretty much it. You have an idea of what's going to go on throughout the day. And then you just make sure that, okay, if you recognize that you see a patient, you're like, hey, you know what? Do we have this piece or this part or anything? And then you make sure you handle it in that morning huddle, because you don't want to get to that patient and be like, oh, I forgot something, or we need to reschedule because we weren't prepared. So that's just another barrier or level of filtering, like making sure we have everything for that day. 9 to 6 p.m. From 9 a.m. to 6 p.m., you see patients. I go from 9 to 1, and then lunch from 1 to 2, and then 2 to 6. So I work out of 2 chairs. If you're proficient, if the doctor's proficient, doctors usually, and in general, work out of 2 chairs with 1 hygiene. So the hygienist is in 1 chair, and you pretty much pop in if they need an exam, and just make sure that, you agree with the diagnosis. Or, well, hygienists can't diagnose. So, the hygienist will be like, hey, doc, I see something here. Can you let me know if it's something, or let the patient know? And then you go in there. Yeah, this is a cavity, so we're going to need to do a filling. And then, and you show take pictures, and then they go up to the front and they get scheduled for their appointment if they need another one. If not, then we see them in 6 months, or depending on their cleaning appointments frequency. The dental assistant, I work with 2. One is a lead, and then one is like a floater. They guide me. So pretty much they tell me, hey, doc, you're going to this chair. It's this patient. We're doing this. And I'm like, okay. So I just hop in, and everything is ready for me to go. I just go in, numb, and then do my work. And then the assistant handles everything from post-op instructions to scheduling or remind the patient of their next appointment. On average, I see about 7 to 8 patients. Today I saw about maybe 12, but that's like crown deliveries and post-ops here and there. For a single doctor on a Monday, usually the goal is 3,000 for production. And then, there's days where I'm producing 10,000, 11,000. So that's a lot of production depending on what you're doing. So yeah, that's just a ballpark, that's just the business standards of running an efficient office. Hygiene checks 1 every hour if it's a prophy. So 9 to 10, 10 to 11, 11 to 12, 12 to 1, Cleaning is 1 hour, hop in for about 5 minutes, talk to the patient, make sure they feel comfortable and they're not a stranger to the office. And then if they need any work, then you let them know. And then you try to do your notes in between because they can add up. So notes, making sure lab work is all correct, filling out lab slips, and checking ahead the schedule to make sure that you're on time. I do work at a fee-for-service office, and we take PPO. We take insurance, PPOs. So for the most part, we try to respect the patient's time. So, we start on the hour or at their assigned appointment time, and we try not to fall behind. If we do 5-10 minutes, we let the patient know. But anything past 15 minutes, we have to reschedule because then the whole day gets pushed back. And then
Right.
6 to 10 p.m., go home, dinner, workout, family time, kind of wind down a little bit. Then from 10 to 11, usually it's more like 10 to 12, 10 to 1, you're studying. Usually I'm reading about an hour a day studying. Studying doesn't end. And then I review the cases if I need them for tomorrow, if I'm doing any surgery or anything like Invisalign. So making sure everything is prepared for the next day or for the week. And just try to get that and just try to stay on top of things. You don't want to, show up tomorrow surprised that you're missing something. So,
Right.
And then bedtime, try to get 8 hours, but realistically, 6-7 hours, depending on, what you got going that day or that night or what you need to do. Cool. All right. So what kind of complaints do patients present with? A lot of patients, a lot of them say I've had a bad dental experience. Does insurance cover this treatment? They come in saying, I'm looking for a second opinion. I'm nervous. Will this hurt? My teeth are sensitive. Doc, you did this filling. Why is my teeth sensitive? I got this crown done. Why is my teeth sensitive all of a sudden? Like it wasn't hurting before you touched it. So these are a lot of things that, like a lot of the complaints that I usually see. Now, with these complaints, you can usually avoid these if you inform the patient of what's going on. So usually if a patient has a bad dental experience, it's probably because like they weren't expecting to pay, then usually it comes down to cost and money when it comes to the appointment. They're like, oh, I didn't know I had to pay. So that's a lot to do with that. This doc didn't numb me. I was trying to tell him that I wasn't numb. So, with that, how I do is I get them numb, you wait 5-10 minutes. Hey, I'm going to drill or I'm going to start my work. If you feel any discomfort, raise your left hand. And you stop in between. You're like, hey, how you doing, Mrs. Jones? You doing okay? Great. We're going to continue with the filling. Does insurance cover this treatment? So before any of the patient sits down in my chair, you go over their insurance, what it covers, what it doesn't cover. Because the last thing you want to do is have them show up, do the treatment and be like, oh, I thought insurance covered this. Why am I paying for this kind of thing? So you got to kind of make sure that the finances are in check and, the patient understands that before rendering any treatment. I'm looking for a second opinion. These patients usually they come in, it's like, hey, this dog wants to do this crown or these fillings. From my experience, what I've seen is they don't trust their doctor or the doctor that recommended it, or they're looking for the doctor to agree with their opinion or what they want. They want the doctor to say what they want to hear. So as a professional, hey, you know what? This is the teeth. This is your condition. This is what we need to do to get you to good health again. And this is what we need to do. And then you stick by that. You got to be stern, because if you don't, then, if the patient can push you around and you start faltering and going back on your treatment, then they're going to be like, oh, you know what? Why was he? I guess I didn't really need that crown when he's just doing the filling. So you have to stand firm. And then it all goes on to patient education. Does the patient understand why they need the treatment? And sometimes it goes down to they don't accept their current health or condition of their oral health. So, they had to accept that. Then they get to the treatment part. And then it's a whole, trying to explain everything. And this can take a few visits if there's a lot of work that needs to be done, or if the patient, doesn't want to listen. So you can't give them all at once. You got to kind of read the patient. You're like, okay, it's going to be multiple consult visits. You know what, Mrs. Jones, I'm going to have you come back. This is a lot of work. I want you to say you come back next week and we can discuss what I see and what we can do to help you get back to being pain-free or being able to comfortably eat, smile again.
So maintaining physician-patient transparency is essential.
Right,
basically.
pretty much.
Yeah.
And like I said, first impressions matter. So,
Right.
if they start to kind of get the sense that you're not confident, they will pick up on that. So then that reflects on their responses back to you, and then you're pretty much at a loss because there's no coming back from that if they think that you're like, who is this guy? Who's this doctor? What is he doing? And then sometimes you just have to be stern with the patient. It's like, hey, you know what? I know you want me to do this, but sorry, Mrs. Jones, I can't. So I'm pretty sure if you go down to the next doctor down the street, they'll be happy to do that for you. But at the end of the day, there is a bigger issue here, and we're not addressing the root of your problem. So my teeth are sensitive. With fillings and crowns, just tell the patient, like, hey, you may or may not feel some sensitivity. It can take up to 60 days, for the sensitivity to go away. Usually at the 3-month mark, if it goes away, then it's fine. Usually it's like right after, where they're like, hey, doc, I had the sensitive. Oh, well, it wasn't sensitive before. Why is it now? And then they got this in their head, like, oh man, he messed up my filling, so he's not a good dentist. And then they go somewhere else. So you have to let them know, hey, we did this filling today. Doesn't mean that we're done. You may need some adjustments and you may be sensitive. Let me have you come back and schedule a post-op visit. Hey, and if they come back, it's like, hey, doc, filling feels great. Great. I'm going to take a look. Cool. All right. So you're trying to manage the patient. If you don't, and you let them be, then they're going to leave. And then you don't know if it was actually your work that you could have fixed, or, if the sensitivity went away, but you lost a patient there, because, it's all about patient management.
That's interesting. So you're a clinician and also an educator.
Yeah. That's pretty much what the dentistry, that's what I learned is, before the patient even sits in my chair, they understand why we're doing this. Because if they don't, and then you do it, they're going to question you. I've had a few patients like, hey, doc, why do I need this crown? You educate them. And then it's like, okay, you don't want to do the crown? Great. But if this happens or you're at risk for this, then this is what we need to do. I had a few patients call like 6 months, a year later, and like, hey, doc, I broke this tooth. I think I remember you saying we need a crown. Let's go ahead. So in the back of their head, they kind of know already. They just want to wait for it to something happens. And a lot of dentistry is like that too, where they won't come in unless they're hurting or in pain. And, you kind of want to just educate and make sure so that when something does happen, Dr. T was the one that mentioned that. Let me give him a call. And you look like, the hero, and be like, oh yeah, like, see, and then now they're ready to move forward. Then after that, they trust you because it's like, oh, he was right all along. So just educating the patient and just standing by what you diagnose. So do a lot of general dentists do a lot of procedures, prophy, x-rays, exams. You can have your assistant do your x-rays. And then I do the cleanings too if I need to, but usually the hygienist does. And then obviously you do the exams. Hygienists can't diagnose. So they can point out and say, hey, there's a big hole in this tooth. But they can't say, oh, there's a cavity there. You can do pediatrics. You can see kids. I deliver nitrous to kids when I do their fillings or stainless steel crowns. Ortho, I do clear correct and Invisalign. So you can do that. You can place brackets too, but I haven't gone into those. Taking CE or perio, doing like scaling and root planing, bone grafting, managing the bone. You have restorative, which is your crowns, for fixed, and then removable, you got your dentures, your partials, cosmetics, Invisalign or veneers, making it look pretty, oral surgery, wisdom teeth, bone grafts, making sure, the ridge and everything is great for surgery, implants. You can do sedation. You can't do general anesthesia, which is putting them under propofol or ketamine and then having them fall asleep. That's like deep, almost borderline deep sedation. So the only things that I use is midazolam, Versed, and I can use some fentanyl, and diazepam. So those are the three main drugs that you can use in sedation, and it works fine. And then there's special needs patients. So in residency, we saw special needs patients, we sedate them. And then, there's a new specialty now for dental anesthesiology. So, hey, you know what? My office is mainly special needs. I can hire a dental anesthesiologist, put them to sleep, and then see them. Same thing with oral surgery. If the patient wants it, instead of sending them to an oral surgeon, but you can do the work, then yeah, you can hire a dental anesthesiologist. Like I said, you can pretty much do any type of specialty work. You just have to hold yourself to that standard of care. And it all goes down to, taking the proper CE, getting the consults, contacting other specialists to practice, to help you practice. And then you got to practice within your scope and refer if you have any doubts. A lot of specialists are happy to help a general dentist. With that, but you also got to make sure you keep that relationship. So that means, hey, Dr. So-and-so helps me with implants. I'm going to feed him some implant cases, stuff that I can't do. And usually nowadays, what I've seen or from my colleagues, a lot of specialty work is now, a lot of specialists are seeing they're like the last hope for the patient. General dentists can do the implants and all that, but like if it's a severe thin ridge or not enough bone, then they'll punt it, send it to the specialist. And usually it's like they get the harder cases. So you want to keep the easy ones that you can do, in your office. And then there's new technology. You got scanning, digital scanning, in-office milling. You can do full arches, crowns, dentures. There's 3D printing now. Cone beam, so 3D imaging of the jaw. You got your guided surgery, so pulling the data from the CBCT, and then designing your guide. Then you can mill it in the office or 3D print, and then you pop it on the teeth, and then you have your surgical guide there. And then nowadays you're doing a lot of same day teeth, so teeth are extracted, implants are already pre-planned in the position with the guide. The dentures or the crowns, are already designed at a fixed reference point from your implants. So then you can just screw it in and then have the lab tech kind of, work from there. So the technology is there, but there is a learning curve and you have to commit to the implementation to your practice. Because once you go digital, you kind of want to invest in all that, and you can't half-ass it because then it's all about the return of investment. So I know my office does a lot of crowns. We probably do 1 or 2 crowns a day, sometimes 3. And I've asked the doctors hey, why don't we have a scanning or we do in-office milling? So their argument is, there's nothing better tried and true than a lab. Sending it to the lab, coming back, and it's very, very accurate. With the milling, sometimes the fit of the crown is not great. It still has some improvements with the material that it's milling. And then, your staff has to learn how to use the technology. And then if you're designing your own crowns, that takes time away from seeing another patient when you have to design it yourself and all that. So like I said, if you're going to do digital practice, which some practices are, you got to commit and, invest in a lot of CE and making sure you're doing it right. Cause it can be, pain at first, but I've seen a lot of great doctors, transition to digital. And I've also seen other doctors who do great, cosmetic work. They're sending it to a lab tech. They're having a guy, hand make these crowns, so they want that eye, that second eye there, not just a machine.
Right.
Cool. So procedures general dentists should know. As a general dentist, you should know how to do root canals, including molars, second molars, and if you can do it, but first molars, upper and lower, and then obviously you're going to do your crown preps with those, and then simple extractions with bone grafts. So that's socket preservation. Those are pretty much your bread and butter. When a patient comes in with pain, you want to help them. So you want to at least be able to know how to do that so that you're not always referring out. Because if you refer out a patient, it's like, when are you going to, you still, in dentistry, you also have to make money. So, these are great practice builders, and these are easy things that you can do with practice over time. So this is a case I did on Friday. I want to say Friday. Yeah, no, Saturday morning. It's an extraction and bone graft. So I'll kind of walk through. I'll show you the photos here, and I'll kind of flip back to this page. So this is tooth number 30. This patient came in, and it took her, I want to say maybe a year or two before she finally decided to, let the office pull this tooth. So there's this tooth here, and you can see all that dark area. That's bone loss right there. So this tooth was mobile, it was moving, and you can see in the picture on the right here, she cracked it in half. She wasn't in any pain. She's like, what, doc, I'm not hurting. I don't want to take it out. But, explain to her, look, you have this infection. The tooth is the source of the infection. Remove the tooth, you stop the infection. If it gets any bigger, you start affecting the teeth in front and the teeth in the back to the point where you may even lose those teeth. So this is a combination of, a cracked tooth. She got some bone loss, so perio. So it's a lot of factors with this tooth here. So severe bone loss. So what we end up doing, she's like, okay, we're going to extract. And this is your classic case of extraction and bone graft. Now, my concern when looking at this x-ray, when I first saw this was, if all this infection got to this point, am I going to have any buccal bone or bone? Am I going to have my 4 walls with this extraction? So that was a risk that, then that's another step of, okay, if I don't have my walls, I need to get a membrane, and then make sure I can build that wall. So you get the patient numb, all right, you give them a block, then let them sit for a while. And then you check, or you go around the tooth and like, hey, Mr. Jones, I'm going to check to see if you're numb. So I get my little instrument, go around the tooth. And what I'm doing technically is getting the tooth ready to be extracted. So I'm trying to peel back the gums from the tooth. Hey, Mr. Jones, all you do is feeling pressure, but not any sharp pain. Are you okay? And she's like, yep. I'm like, great. So then she thinks I'm still moving around, but I'm like, now I have my elevator and I'm pushing up against, a clockwise fashion. So I'm pushing up against the tooth. I wedge that thing in between the tooth and the bone. It's pretty much like a screwdriver. And what you're doing is you're trying to expand the socket. But in this case, it's pretty easy. It was moving already. So it's just a matter of breaking the fibers. You dilate the socket, expand the bone. And then at a certain point, when it's ready, you get the forceps, and then you kind of just hug the tooth, and then you grab, and then you kind of move it, and you deliver the tooth. With this case, the tooth came out fairly quickly. The part that took me the longest was on the socket, there is granulation tissue. So when you're doing bone graft sticks to bone. Bone graft does not stick to tissue, or else it's going to fail. So I spent probably 30 minutes cleaning out the socket, trying to remove that tissue so I can see bone. Here, and I'm going to flip back one more time. After that, you reach the bone, you stimulate bleeding, and then you pack the graft that I stabilized with a Healy plug, covered it up, and then sutured. And then I took a post-op x-ray. Luckily, I had 4 walls of my socket, so I was pretty confident that I was confident that the bone graft will stick and that we'll have a good result. So there's the case, there's the tooth, occlusal shot. And then this is the whole elevating and then delivering with the forceps. You can see here, it's like a screwdriver. You go in between the bone and the tooth. Because then what you don't want to happen is, and this happened in residency. It wasn't me, but it was an oral surgery intern or student where she took out a premolar, but then the canine also came out. So then, she's like, hey, I need something to splint this tooth back in. So you want to make sure you wedge it in between the bone and the tooth that you're trying to take out. And then you have the forceps here, and then you wiggle or you move left and right, expanding the bone, and then sooner or later it will give. Oral surgery is all about finesse. So you're finessing the tooth out. You're not being rough with that because you want to preserve, the bone structure that houses the tooth for the bone graft. And so this is a warning for some bloody photos to follow. All these photos that I take, are my photos. A good thing in dentistry is to invest in a good camera because that's what you want. I think these ones were taken with an intraoral camera. So you want, and this goes back to the educational piece. I take photos of all my new patients, what their teeth look like before. So when you blow it up on a big TV, they're like, oh, this is what my teeth look like. And then you're not lying to them, and like, hey, this is what you need. And then they're just relying and trusting your word based off, your word instead of photos. So I took the tooth out. There's some granulation tissue in the middle. What pretty much happened is the gums just grew into the tooth, into the socket. And then, it's not attached to the bone anymore. So that's why it was floating. And that's why you saw that dark area on the bottom. Just the tooth removed. And then you can see in the next photo over, the socket is curetted. You can kind of see the gums is beat up. Okay. So those gums right there is okay. You're going in there and you're scraping, and you can kind of see in the middle here, that's bone. So this little centerpiece right here is pretty much gone. You want to clean all that out, clean out all the infected tissue, and you want to get the clean, solid bone so that you can put your bone graft in there. And then you put your bone graft in your synthetic material. Usually it's a cadaver, human cadaver, and or pig, porcine. And then, there's some patients that are like, oh, you know what? I don't want that. I haven't had a patient say that to me. But there are other, non-animal options or non-human options for that. It's not a lot of those. You don't come across those too often.
Right. Just out of curiosity, how long does it take for the graft to regrow before moving forward with treatment options?
Right. So it'll take about if it's a bone graft, 3 months, 3 to 4 months, give or take. And then you do your post-ops, you take your x-rays, and then, hey, you know what? It's 4 months, but I want to see you in another 2 months before. You can do that. Okay. You take your cone beam, you get a 3D structure, and then that also gives you a better idea. So it all depends on the post-op. I know there's always this 3 months, but it's all at the discretion of the provider. Patient understands it's going to be a long process. So, they'll understand if they have to wait another month or 2. So you put the bone graft in, you can see I started to pack it, and then kind of get it in there, you condense it. And then on the picture to the right, you put a little Healy plug. It's like a synthetic collagen material. You put it on top to kind of keep the graft in place. And then you place these sutures and then kind of hold it down, and then, stops the bleeding and all that. And then you take your final x-ray, and then you can kind of see here all the graft material filled in this bone graft or this socket. And this is what you want to see. And then over 3 months, it's going to remodel and look more like bone, transition over, and then it'll be ready for an implant, pretty much. So extraction bone graft. I know I talked about root canals, but I'm going to transition into the next case, because the next case also, if you're doing this type of case, you should also be placing that implant for this socket. If you know how to do these bone grafts, there's no reason why you shouldn't be placing implants. And if you've done it, you know what the socket is, you've been there, patient trusts you, placing the implant should not be a problem. So it's an extraction bone graft case, and then I'll transition next to an implant case. So as a general dentist, practice builder, at least when you're starting out, you have to be comfortable and proficient removing teeth and placing bone graft. That's like your basic. It's like doing the filling. Patient comes in with pain, you want to be able to help them instead of referring. And then it sets the stage for an implant placement in the future. Easy, it's a practice builder, and then it also adds revenue to your office. You're not losing money in your practice. So, because you do have to make a living also. And then, like I said, you practice within your scope. It's like, hey, you know what? You did the bone graft, but it may need additional bone graft. Then you may want to refer, or if you can do additional bone grafting techniques like tenting, where you put a screw in, and have a little membrane that holds it up and add more bone graft, then you can do that too. It all depends on what you're comfortable doing. So here is an immediate implant placement. Baby tooth, and she didn't have an adult tooth here. So this tooth number T, and you can see on the bottom left, right next to the root canal, that's a baby tooth, and she has all her adult teeth. And then she has a cavity on that tooth right here. So this is the beauty of, now this is my SLR camera, the detail, for your learning purposes and for documentation. So that's another thing to also think of for those who got into dental school or trying to get in, documentation, taking photos and learning from them. I wish I did this sooner in dental school. I didn't do it till after I got out. So it's something that helped me a lot, and then helps you kind of review your cases. So going back to this case, she came in, broken tooth, but it's a baby tooth. Usually, you do a filling and or crown it, but the tooth was also mobile. So we opted for an extraction and placed an immediate implant. You don't have to do an immediate implant. You can extract, place bone graft in there, and then come back and then place the implant. But since here in this x-ray, there was plenty of bone beneath the baby tooth, and at the right depth, I can get the implant in there. The question is, will the implant and the surgery, will it go well? And that happens too. If you're out of angulation, you can always close it up, put bone graft, come back another time and try. And then you can also do guided with this case too. So I took the tooth out, and then you can see in the photo on the right, I made my osteotomy. So you work through a sequence of drills. It's like putting a stud in the wall. You put one small drill, get it to where you want the angulation of the implant. Then there's this thing called a parallel pin, where you're like, all right, I'm going to check this to make sure I like where my implant is. So you put it in, you take an x-ray, and you know what? I need to adjust. With that's your thinnest diameter, so you can always adjust. Once you get any bigger, it's hard to compensate or make adjustments. So that initial drill is important, and it has some leeway if you make a mistake. So if everything's good, I like my angulation, then you make the drill size to the depth that you like, and then the length of the drill, and you just keep going. So same length. I think this was 11.5 millimeters in length, so it's a consistent length. But what's happening is as you go up in drills, it gets wider and wider. So this one was a 4.8 millimeter diameter implant placed at its length was 11.5 millimeters, I want to say. If not, it's probably 10. And this, I'm getting technical here, but the idea is you kind of pre-plan your implants. You got to kind of want to know where your implant's going. And then you also have a few implant sizes where it's like, hey, you know what? Maybe this is too long. You can downsize to a 10 millimeter implant. It's not a problem. So there's an implant in place. You place the implant. You can see it's deep. And with immediates, you kind of want to sink these in lower because of bone remodeling. So there's an implant. And then here we're doing a 1-stage. So 1-stage meaning I don't have to go back in, open up her gums, find the screw, then put a healing abutment to train the tissue. Here, I'm already putting, it's called a healing abutment, where the tissue is just going to grow around it and then train the tissue. And I don't have to go back in and do a 2nd-stage surgery. So it saves 1 surgery, and it saves you about a month there. So once you're all done, you get your implant in, you take the x-ray, obviously. Okay, great. I like it. Everything looks good. You torque it. Usually these are torqued out at about 40 Newtons. And then you have a little gauge when you're screwing it in. And then you put your healing abutment. And then this right here, she came back a week later. And then this is what it looks like, So she's healing, no complications. She's not having any pain, no infection. Great. So we let this cook or heal for about 3 months before I go back in and then take this implant or take the cover screw out and get it ready for an implant crown. And I didn't have time today, but I was able to deliver this case, and she liked it very much. Very, very happy. And I think we had a good result there. So, this is immediate implant, placing implants. They're the same thing. You're drilling a screw in a patient, putting a crown. What's hard, or what the clinician, what you have to understand, is managing the complications. If something goes wrong during surgery, what are you going to do? If a patient comes back with an infection, what are you going to do? Prosthetic wise, the reason why a general dentist should do implants is because the dentist, you do crowns and fillings, right? As a general dentist, where, I know where this crown is going to go and how it's supposed to look right out the bat. Okay, great. I know where this crown is. Now I can figure out where I want my implant to go so that my prosthesis or my crown is where it's supposed to be. So I am dictating my implant placement because I have an idea of where my crown is. Oral surgeons, they do surgery, a lot of them are great at their surgery, but a lot of the issues, even in residency, or when I was in residency, or even in dental school, is all they would do is drop the screw in, no regard for, okay, you as a general dentist come back with this screw, and if it's not placed properly, how are you going to restore it? Now you're on the hook for this implant. Oral surgeons, all right, patient's gone, I placed the implant, let the doctor figure out how to put a crown on there. But, the implant's great and it's going to stick and it works, So this is why I think general dentists, you should know how to place, if you're doing crowns and you're doing extractions, you should know how to place implants. And it can be simple implants. This is a simple implant, by design. And usually it's molars, premolars that you should be able to do. If you want to get a little adventurous, it's the front teeth. Those ones can be a little bit trickier because it's the front tooth. It's going to be an aesthetic complication, if anything. And if the patient doesn't like it, then, you're kind of screwed. So it's all about case selection also. Are you willing to risk the headaches for this? Or would you rather have a periodontist or oral surgeon take responsibility for this case? So yeah, that's my 2 cents on, learning, why general dentists should place implants. And you'll get a lot of there's a lot of people, in social media, you're going to get general dentists shouldn't be placing implants. You should place implants, within your scope. So it's just all about practicing and being comfortable. And that goes with residency training, picking the right patients. If you mess up, you just let the patient know, hey, you know what? I messed up on this case. We need to redo it. Chances are they're going to be like, okay, if this went wrong, I would have told the patient, hey, I got to remove the implant, put bone graft. Okay, we'll come back 3-4 months. Let's try this again. Chances are they'll be okay with that. It's when you're trying to make an excuse for treatment that failed, well, they're going to pick up on that. And then you're kind of digging yourself a hole. So as long as you own up to your mistakes, Patients appreciate that. And dentistry is a practice. It's never perfect science. That's why we call it the practice of dentistry, because every case is different. You learn something new every time. So it's 1 week post-op. And then we did this implant back in, I want to say September, and then let it heal. And then, January holiday season. So we were able to deliver her crown today. Had to send it back to the lab a few times because it's more of a prosthetic issue with the impression. The lab didn't do things right or properly. So that took about 2 weeks of our time. And then there's our implant when it was done. So yeah, that's post-op. There's a 1 week post-op pano. And then, yeah. So advice to future dentists. You need to know why before you know how. So understanding why you're saying things to the patient before you get to the treatment. Dentistry is pretty technical. You're going to learn that in dental school. You'll be fine. And then there's always CE courses that you can take to get better. It's being able to recognize on the patient, hey, this is what you need. This is why you need it. And then once you figure that out and they say yes, and then getting to the end result, there's multiple ways. So there's more than one way to skin a cat, that saying. So, there's more than one way to get to a crown or a sequence treatment. But as long as you know your end result and why you're going there, then that's what is important. And this is one of the guys, Dr. John Coyce, very, very famous in the CE world. So very, very good CE lecturer. It's something that I would look into for those who are, in the future, big name. Take a lot of CE. Learning doesn't stop. It doesn't stop after your dental degree. So the craziest thing about dental school is once I got into residency, the first thing the director said was, all the stuff you learn in dental school, forget about it. And I was like, what? He's like, yeah, you think you know, but you don't. So you're going to learn, and then you're going to learn again. You're going to get rid of some things, and then you're going to learn some more. So that was like the biggest thing, because you paid all this money. But in the end, dentistry makes you a minimally competent dentist. Okay, so that allows you to go out, do your basic fillings, drill and fill and all that. But if you want to do more than that, then it's your responsibility to go and seek those out. There's a lot out there. Pick the ones that you like. Talk to a lot of people who take CEs, and then CEs get expensive. So you want to pick the ones that's worth investing your time on and the ones that you see yourself doing in the future. Start documenting your learning. So starting now, if you're shadowing a dentist, take photos of, those whitening trays and how you do it, because you're going to learn how to do that in dental school. Take trays, instruments of the setups and all that, because it all comes back. You probably won't touch it for a while, but it'll all come back in the end. And it comes full circle. So if anything, if you're in dental school, get a decent camera, take pictures of everything. I wish I did, because then that would have been cool to kind of look back and see the cases that I've done before, and then you can kind of see your progression. 3 golden rules to being competent is practice, practice, practice. Even when I'm doing veneer cases, I got a dentiform, you buy some teeth and you just practice. You're not practicing the actual tooth per se, but you're practicing the sequencing, making sure you know your steps from A to Z, everything. So run it through your head visually, have your notes out, because over time, once you repeat it, it's going to become second nature. But you practice. And then you also kind of want to push the envelope a little bit, so it's a fine line between what you're comfortable and what you're trying to push for. So those kind of got to teeter totter and practice within your limit. I think it's one of the best professions out there. I know I recently saw that we were just ranked number 2, and then USA Today ranks the dental profession at number 5. You get to help people. There's multiple avenues to expand. It's never a boring day. Like today, what did we do? At my other office, internet went down. Got to call AT&T, got to troubleshoot that, making sure my patients are on there, it's stuff like that. You're putting out fires as a practice owner. And then also being prepared for what the day brings you. I used, like when you walk in, whatever's on the schedule, you got to be able to handle it. So it's never boring. You do make a good living. You're not going to be rich, but you'll be comfortable. You'll be flexible. You can be able to spend time with your family. You can make your own schedule. What other profession, at 12 o'clock when you're done with patients, you can have your hygienist work, and then you can just hang out, for the rest of the day. And you can do whatever you want. You can Tuesday and Wednesday, Thursday work, and then take Friday, Saturday, Sunday. It all depends on how you want to build your life around dentistry. Don't do dentistry for the money, because it's not going to be there. I know a lot of doctors who used the dental money and then gotten out of dentistry and now practicing once or twice a week, because you do get burnt out, and then they're doing other things like teaching, courses for other doctors, consulting, all that. So there's a lot of things you can do with it. I think dentistry is, it can also be stressful. And you got to put a lot of work into it where you want to, if you want to get to where you want to go, but it's not going to be easy. So yeah, but I think it's really great. It's served me well. It's been pretty good. I get to enjoy my time. My friends are working a 9 to 5 when I'm at home chilling, or, I'm done for the day or something. So there's a lot of things that, you can enjoy and benefit from dentistry. Cool. And then, yeah, that's pretty much
Boom.
it. Yeah.
Awesome. Thank you so much for sharing, your day-to-day, a few of your cases, and also illuminating sort of the depth of general dentistry. At this point, I'll hand it over to Kathleen, our chat moderator, so we can answer a few questions from the chat before concluding today's session. So Kathleen, feel free to take it away.
Perfect. Thank you. So our first question is, what would you have done differently during your first round of dental school applications?
So at first round of applications, I pretty much applied to schools that sounded cool. UCLA, USC, oh, let's go to Harvard, UNC. No. Then my buddy who got in was like, hey, you should check this book out. So I don't know if they still have it. It's probably a third-party book where I had my stats, and then you go through the book and like, this school takes average GPA is this, their average DAT is this, cost of living, how many out-of-state do they take, how many in-state students do they take. So now I'm finding schools that I fit into with my stats. So that was what happened my second round of dentistry. The first time I just picked a hat. I only applied to like 5-6 schools. Thought I would get in, and mainly California schools. But that didn't happen. So then second time around, I had to kind of figure out, be more strategic in applying. So you got to figure out what schools are good, and all that. Obviously, you kind of want to stay in-state because your in-state tuition is a lot cheaper. But out-of-state, it's good. So it's just a matter of, getting into dental school, and obviously where you want to go. You got to do your research, and then there's a book that breaks it down by demographics, all of that. And that's what my second round intel was. I was able to pinpoint and be like, I think this school will take me. I think this school, I fit well with this school. Okay, this school too. And then 26 schools, it's a lot of money. Then I had 5 wait lists, which means 5 interviews. I had 5 interviews, and then your travel, flying time. Okay, and then picking the school that you want, and hopefully you get into one. Not a lot of people don't get into their school, their first choice, which is okay. You just got to make the best of it. You got into dental school. If they gave you an interview, that means they liked you. Other than you look good on paper, that's pretty much why they gave you an interview. Now you have one foot in the door. What are you going to do to convince them that, hey, I'm not just a 4.0 student, worked at a dental office these years. I also do this. I'm interested in this. I do art, something that will take them by surprise, pretty much.
Right.
As a dentist, do you attend conferences or conventions to brush up on your skills?
Yes. So as a practicing dentist, every 2 years, you're required, I want to say 50 hours of CE, 25 online, 25 in person. I average usually about 100 a year. And, that's a lot of CE. My first few years, there was a lot of CE. This year, I'm taking about 2. So conferences, not so much conferences, but so my CE course is the COIS Continuum or the COIS Center. So it's a continuum. So he has like 9 courses and you take it over a span of 3-5 years. And you spend about a week at a time there. So you go there, you do your CE, you get your hours, and you come back. With these conferences, once a year, there's the main one, the California Dental Association. So I do show up for those. I get to see what's up to my friends. And then I went to the Midwest one because when I was down in Indiana, all my colleagues, we will go out to that one. That's one of the bigger ones, the midwinter one. And that one usually you go there once, twice a year, or once or every year, every other year, depending on what. For those conferences, it's more or less trying to see what the technology is, keeping up to date with the dental industry and trends. And then just seeing colleagues, and it's pretty much a bunch of partying. I'm not gonna lie. You just go there, hey, I want to take the CE, but you're not really taking CE. You're going out there to see all your friends, colleagues that you haven't seen since dental school, and then you just go and have a good time. So yeah.
What are some tips you would give somebody who is starting to shadow a general dentist?
So shadowing a general dentist, it's kind of, so from my experience, when I had a student shadow me, I was pretty involved. Like, they were able to help me assist, but that's also because they had their dental assisting license, or they were a dental assistant before. So being able to just say, I want to observe, take notes, and then chances are you may, if you can work there, then that's even better, because then they'll train you, and then you're technically not quote unquote shadowing your work, and then you're doing the dentistry. You're getting behind the scenes, you're doing the work. Because I know if you say like, hey, I want to shadow, but then, they're also running a practice and it's busy, they kind of want to keep things flowing. So they may be less inclined to be like, hey, this is this, this is this, this is this. It's more like, hey, you're just gonna come hang out in the office and see things. So it's more of like, I would probably just try to apply and see if you can get a job at a dental office as a dental assistant, or even as a front desk, just to kind of get yourself in the office setting.
Do you eventually get desensitized to blood during dental school?
Yeah, I mean, I was pretty desensitized even in undergrad. I had one assistant when I did a full mouth extraction, and it was her first time. She just did dental assisting school. I brought her on. Hey, we're taking these teeth out. She handled it pretty well, but then at the end, she's like, I've never seen so much blood. Then now she's used to it. She's been with me for about 7-8 months. So now she's used to it. So yeah, you become desensitized. And then if blood is not your thing, then you don't have to do extractions or surgery. You can do other things that don't require you to see blood. So it is part of it, especially when you're doing deep cleanings and the gums are bleeding, you will see it. But yeah, you do become desensitized after a while. Like for instance, on my lunch when I'm eating, I'm pulling up cases that have blood all over them, and my staff is like, you can do that? You can eat while looking at, a skull cracked open, stuff like that. So yeah, you do become desensitized. It's pretty cool though.
Well, thank you for sharing. Unfortunately, I guess just in the interest of time, that's all the time we do have. But
Cool.
Doctor, we want to thank you for your time and also your effort to sort of help students navigate their pre-dental career paths, amidst our current situation. But thank you again. That was amazing.
Yeah. Thank you guys for having me on. Appreciate it.
Yeah. And just before we conclude today's session, I want to remind today's viewers and today's attendees that the quiz should be posted in the chat once we conclude the session, and it can also be found in our Instagram bio. And on that note, we want to thank everyone for attending, and we want to wish everyone a good evening. Thank you again, Doctor.
Cool. All right. Take it easy, guys. Thank you.
Awesome. Take care.